So with due permissions, I'm just going to start with last of my lectures for this conference. I'll take this opportunity to thank you all again for being patient listeners and very enthusiastic learners. Ultrasound and hip. Now, we may think that hip is a very big joint and so it should be very easily accessible, just as we thought and we proved that knee was, but there are intricacies in understanding and the techniques of the hip joint, which I hope that through the presentation I will be able to elaborate and bring you closer to how an ultrasound of the hip should be performed. And these are the random ones, and we all know the indications for doing ultrasounds of the hip joint: effusions, insertional enthesopathies, bursitis, infective pathologies, hernias, trauma, impingements, palpable masses. Most of all today, there are lots of hip replacements that are being done, so arthroplasties, which need to be evaluated sometimes because there is no other way of evaluation in a cross-sectional modality without having to compromise on the image quality. So when we start hip joint, this is actually not an ideal position. The ideal position is that you externally rotate the hip joint and flex it at the knee joint at about 45 degrees in order to achieve the complete open the entire structures that need to be evaluated from the medial to the lateral and vice versa, or from the cranial to the caudal. In this view, you can easily appreciate that it's an oblique coronal. So it's an oblique coronal placement of the probe in order to visualize the anterior joint recess, which is of the hip joint. This is of a child, as you can appreciate that there is an epiphysis and an epiphyseal growth plate with the metaphyseal region. However, in the adults as well, the probe orientation remains the same for us to see the anterior joint recess, which is in direct continuation with that of the anterior joint of the joint cavity of the hip joint. And what we see here is exactly in the same manner. We see the fluid, or we see for the synovitis. Also, this is the region where we actually look for the occult fractures of the neck of the femur, which sometimes get obscured through the x-rays, which may be ill-positioned at the time because of patient pain and rest of the things. So what we are talking about here is that if you just observe this region of the anterior joint recess, what we have is the joint capsule, the iliofemoral ligament, and over and above, of course, what we are seeing here is the tendon of the iliopsoas. But in effect, you can see that there are some mid-level echos that are seen here as compared to the echo-free region that we are seeing in the proximal region of the joint cavity or the anterior recess. Now, this, of course, happens to be what we say is the synovitis, because this was not displaceable but compressible. So we have to make sure that when we do a scan, we must put the color Dopplers and look for the synovitis that may be there along with the effusions. With the synovitis, we are talking of hyperemic changes, which we have gone over through our presentations again and again, that as soon as you put your focal areas of the color Doppler, what you elicit are, in these middle level echos, a vascularity, which differentiates it from synovitis. However, if there is no vascularity, you don't say it's not synovitis, but you do give an impression that it could be a hemorrhagic content or a pussy content. But if we have a positive area where we have a vascularity coming, of course, we say that it's synovitis. Now, the anterior scan here, what I've shown you in this image of short axis scan is from the lateral going on to the medial, and these are the soft tissue markers for evaluating the anterior hip just at the level of the inguinal ligament. So what we have is the tensor fasciae lata. It's a muscle which originates from the anteriormost edge of the iliac crest, and this then goes on to insert into the iliotibial band laterally. Of course, underneath that is the short axis scan of the rectus femoris, and as we will go through our live demo, as we move our probe cranially or proximally, it tends to become a tendon which inserts into the anterior inferior iliac spine. Sartorius, a short axis of sartorius, which again, when we move laterally and proximally or cranially goes into converting into a tendon which inserts at anterior superior iliac spine. And of course, this is what is the formation of the tendon of the rectus femoris, a short tendon that's getting formed, and of course iliopsoas muscle. If we go even more medially, what is it that we will see? We'll see the neurovascular bundle, we'll see the femoral artery and the femoral vein and the femoral nerve. And if we go even more medially, we end up seeing what is called as the pectineus muscle. This is again a short axis scan of from where we were. We have gone even more further cranially, and what we see is the short axis of the tendon of the direct tendon of the rectus femoris, and the distal shadowing that you see is little because of the anisotropy. In a long axis scan, this is the tendon of the direct tendon which is going over to the attachment at the anterior inferior iliac spine. And there are two tendons of the rectus femoris. There is one which is a reflected tendon, another is the direct tendon. So the direct tendon and the reflected tendon goes and inserts and merges with the capsule over the acetabular, superior acetabular surface. We will be more happy. So this of course becomes our iliopsoas, the rectus, and of course the tensor fasciae lata. Underneath is, of course, the area which gives the hip joint its recess, and this again is the tendon or the direct tendon of the rectus femoris going into the anterior superior inferior iliac spine. This, of course, is the short axis, which has to be kept in mind as we will go through our live demo. Do please remember that there is an anisotropy, and when you see this anisotropy, that's when we turn it into a long axis to see for its insertion at the level of the ASIs. Rectus femoris is a tendon which is most prone to injury. That's the direct long axis scan that we are doing. This was an x-ray that came to us. There was an avulsion that we could of course see, but for clinical interest we put our probe. And what was this? Was a normal, of course, the rectus femoris tendon, but at the level of the symptomatic hip we could see that there was an avulsion, and we were able to see the echogenic foci of the avulsion that was coming from the anterior inferior iliac spine. The labrum is something which has a very dogmatic view that labrum is something which cannot be seen through ultrasound. It can be seen, but if you want to go and look at the entire extent of the labrum, definitely we need to see an MRI image along with it. But again, what we are saying is that ultrasound becomes the first step modality for you to indicate in what direction you should be doing. And if amongst us we are doing MRIs, those small pics, when you're sitting down even on your console, it takes you longer to reach that place, and it's easier and shorter through an ultrasound. This was an Afghani patient who came to us with pain anterior hip joint, and there was nothing that we could see, and we were doing a dynamic scan of the flexion and extension and external rotation. And when we were doing the external rotation, he would say it hurts, and that's when we found out this is the, of course, on the right split screen image, we have the asymptomatic, and in the left, the symptomatic. And when we just for the clinical interest, we put down the areas, we could absolutely see that there was thickening of the anterior labrum here. And when we found out that what is it that could have happened, he said he had no injury as such, but he said that as a young boy, when he used to play football, there was a time when he tripped, and this is how a long-standing injury of the labrum can look like. Again, this is to reiterate the head of the femur, ilium, acetabular margin. This is the anterior joint recess. Over that is the capsule, the iliofemoral muscle, which gets converted into tendon to get inserted at the lesser trochanter. So we are talking of bursas, and the largest bursa in the hip joint is the iliopsoas bursa. When it is not distended, of course, it's not big, but when it distends, it can go to almost carrying about 50 cc's of fluid. This is a transverse axis of a patient. This is a young lady who had come to us with pain, and this is a static grayscale image of how the iliopsoas bursa looks like. And these are just few images of the iliopsoas bursas, but I have a clip here and I hope it runs. And this is a lady where this is a static image of the ileus bursa for you to keep an impression in your head. And I'm going to run both the clips together. So this was the asymptomatic side, and this is the symptomatic side. And as we were doing the lateral and the medial rotation at the hip joint, we could actually elicit that there was a bursa that was coming up on the symptomatic side where she was complaining of pain. And this, of course, the normal side, which remained showing no fluid at the level of the ileus bursa. And in the complete stress ultrasound, this is how the bursa actually shown. If also here I would like to bring to your attention a small area of irregularity that was there at the neck of the femur. And when we saw that irregularity right here, it is the time when we really thought that, because there was, if you can see that irregularity, and if you'd go to the normal side and keep moving the clip, you would see that there is hardly any irregularity and there is a smoothness. So ultimately this turned out to be the patient. This was an FNAID, and the fluid showed that she had Cox at this point. Infected implants, we have again and again spoken about how a person with implant is much happier, and the radiologists and the clinicians are much happier getting an ultrasound done, because with the MRI and the CT images, there are artifacts that come up, and these artifacts can sometimes compromise the understanding of the pathology that lies underneath. This was a patient who again came with the internal fixation for fractured neck femur, and he was the person complaining of pain again and again. The normal side, actually, this has a step deformity, but this was just osteophyte that was sitting here and not a fracture. But on the infected side, we could see a fluid collection, and these images, these echogenic foci are of the implant that were put in there, and this turned out to be a hematoma which was just not resolving and was aspirated. It was earlier thought that it could be an infected hip. Insertional enthesopathies, I think the term in itself is extremely explicit, where we say that wherever there is an insertion of the tendon, there is always a point of contact with the bone, and that can result into, due to overuse, due to acute, chronic, repetitive injuries, can result into changes in the tendon as well as the underlying cortical bone where it takes its insertion, and leads to multiple gamut. It's not necessary that you should have all thickening, irregularity, inhomogeneity, or loss of the fibrillar pattern, calcification, tears, ruptures, all at the same time. But any one or any two of them will always tell you that we are dealing with an insertional enthesopathy. Enthesopathy, enthesis, where it takes its insertion. It's a very simple explanation. So we have a lot of insertional enthesopathies in the hip joint. The commonest, we talked about rectus femoris. We're going to come to the next one, and which is the adductor insertion. So adductor, there are three muscles, longus, brevis, and magnus, and all three of them actually unite to form a common tendon which inserts on the pubic tubercle. As you can see here, this is the orientation of the probe for the positioning, and as we see how we differentiate, that is the, I'm sorry about the annotation here, which is reverse annotation. That is the adductor magnus here, adductor longus here, the D, please just, so adductor longus tendon and the adductor brevis and adductor magnus, and all three of them go on to insert on the pubic tubercle. That's a normal picture or an image that you see. However, when there is an insertional enthesopathy and a long-standing one, you see these multiple echogenic foci, which are calcifications within the tendon. Sometimes there are tears, hematomas or hemorrhages go on to organize and give varied picture. The best part is that as soon as you go into that region and you press with the probe, that sonographic palpation gives out an which you can correlate with your findings and bring back some sort of a diagnosis to the patient. When we are doing a lateral hip scan from the anterior, we move on to lateral and lateral hip scan. The primary mode is a transverse or a short axis scan, because the greater trochanter has a long, irregular kind of configuration. So we go first in a transverse axis, and we go transverse axis all the more proximally and distally in order to evaluate the entire extent of the greater trochanter. What you see is a pyramidal kind of a structure, and greater trochanter takes its the insertions of gluteus medius and gluteus minimus. You will be, of course, talking about why gluteus medius comes on the anterior facet, and on the posterior superior facet we have the gluteus medius. There is an avulsion which is seen from the underlying cortical bone. You can see the donor site as well here, and that's a transverse of the normal looking greater trochanter with gluteus minimus and medius insertions. When we put our color Dopplers, of course, we want to know if there is some sort of a vascularity which gives us a clue to the inflammatory or any other response. And so we never forget to put just one hand should be on that color Doppler button which goes press, and you can see a multitude of things. This is a longitudinal scan of the same greater trochanter where we could pick up a small chronic tear of the gluteus medius. So again, we have the gluteus minimus and the gluteus medius, and this goes on to give us the clue. This is a long axis scan, just an image for you to understand how and why the gluteus medius minimus comes and takes its insertion on the anterior facet, gluteus medius, and the gluteus maximus takes its insertion into the iliotibial band or the fascia lata on the lateral side, which covers and extends from the gluteus down to the insertion at the tibial Gerdy's tubercle. Gluteus medius, trochanteric bursitis. Again, we have three kinds of bursas. We have three big muscles. So we have gluteus maximus, subgluteus bursa, gluteus medius, subgluteus bursa, and of course of the minimus as well. The largest, of course, usually is the gluteus medius, which gives the result of pain and a very focal kind of a pain over the gluteus over the greater trochanter, and the fluid of bursa would look like a fluid of bursa anywhere. It's just what the mind should know and the eye will show you. That's what the ultrasound will give you as the proper technique. So those are the bursas. As you can see, this is a superficial trochanteric bursa, and the deep bursa, which is of gluteus medius here, seeing a deep trochanteric bursa, you can also call this. And every muscle, the gluteus maximus and the gluteus minimus, both have their own bursa, which according to the nature of injury would get inflamed or would have effusion for us to understand where we need to take our probe. So we've already talked about the bursitis. Dr. Samir talked about pseudo hernias. We are talking about the true hernias also. That becomes a part of the anterior hip pain scan. So this is just to reiterate here the fact that if a patient with anterior hip pain comes, do not, in the interest of time, also overlook to see for the hernial sites. It could be because of an indirect hernia, direct hernia, and what Dr. Samir said was a pseudo hernia, which we call as the sports hernia, where because of either the neural compromise or because of a deficient anterior wall, there is a hernial, no hernial sac, but there is a push of the internal contents on the anterior abdominal wall, which gives a very typical kind of pain, especially in patients. You would have to just ask them, "Dard kab hota hai aapko?" And they would all come back that I am running, and then suddenly I turn. And as I turn, I get a very funny kind of pain down in my abdomen. That's because that part of the abdomen, due to rotational speed, gives the prominence of the internal organs. And I'll just go on to show you a clip. This is a clip here, and this patient was a young patient. These are sports hernias, or the sports hernia, or what pseudo hernias talked about. These happen only in very young patients, young athletes with deficient anterior abdominal walls. So this is, of course, the two clips that I'm talking about. And as the patient stands, and we are just putting the probe pressure to see whether the contents come or not. This, of course, is the asymptomatic side, and this is the symptomatic side. And as I put my probe pressure over it, you can see that even though there is no defect, but the internal contents actually protrude out and press on the anterior abdominal wall, which is not happening on the on the asymptomatic side. They don't protrude and put an impingement, but here there is sort of impingement, and this is something which needs to be evaluated every time there is a person who comes with hip pain. Snapping hip syndromes, if you have heard those snaps, you would know that the one is a soft snap, another one is a huge snap. The patient comes and says, "Awaaz aati hai." So the big snaps are usually external snaps, and the Soft ones are which are coming from the internal hip. So I'm not going to go into the depth of this. I'm just going to touch upon the iliotibial band syndrome or iliotibial fasciitis that happens, the fluid that comes, and these are called as very typically iliotibial band syndromes. They are also called as the runner's knee or runner's thigh, where the iliotibial band rubs against the greater trochanter or down at the knee and gives fluid thickening and loss of that fibrillar, or we can't call that a fibrillar pattern, but the clarity of the fibers of the iliotibial band actually lose that, and what we have is iliotibial band syndrome either at the hip or at the knee joint, and it needs to be just kept in mind every time we are talking about pain on running. And the runners usually have this, and these are chronic repetitive injuries. They are never acute injuries. Sometimes there can be tears also. This is a thickening of the iliotibial band that you can see at the level of the greater trochanter when there is a rubbing of the iliotibial band constantly against. Intra-articular pathologies are now we're talking about the impingements. These are very favorites of orthopedicians. The first question that anybody asks when we're doing ultrasounds is, can you look for the impingements? You say yes. Pincer type? Yes. Cam type? So there are two types of impingements. In very short, a cam type where there are bumps which are there on the head of the femur. So these are called cam types of bumps, and they usually happen in male population. They're not seen so much in ladies. And then there is what we call as a pincer type of an impingement, which you see in obese ladies, multiparous ladies, where there is an irregularity of the acetabular margin. I will go on to explain that in a later slide. But this is a cam type of a bump. This was again a young patient, 17 years old. He came with restricted flexion of the knee joint and pain, and when we did a dynamic scan after having done the entire thing and not finding anything, when we did the dynamic scan, what we found, there was a cam right here. Cam is, you can just say bump. So there was this bump and a cam, and every time there was a flexion of the hip joint, this cam was impinging on the iliopsoas tendon and giving pain to that young man. What are the treatment? These treatments are usually surgical, where you shave off these cam or bumps, but it's an extensive injury and it needs to be understood. Now we are talking again about the pincer type, where there is actually a destruction of the acetabulum, and this again leads to a very typical kind of pain, which is an impingement pain. This is again on the right split screen image, you can see how a normal acetabular margin or the bony acetabular margin would look like. And this is where the destruction was, leading to an impingement and pain in this lady. This also turned out to be evaluation post fall, which the lady couldn't remember, but it was that there was a history of trauma here. So then we are coming back on the posterior gluteal side. That means we are talking of the posterior hip evaluation, and there are certain basics that we run through. We look for, of course, the gluteus maximus, and we keep seeing the layers underneath. But an important part which some people do not want to accept, that there is something called as piriformis syndrome, the muscle of the piriformis. So that's the piriformis muscle, and the piriformis muscle underneath runs the sciatic nerve, and when there is an edema of the piriformis muscle actually takes its insertion of the greater trochanter through the greater sciatic notch, and it impinges when it becomes inflamed. And common is in bikers who keep their purses or the wallets in their back pockets, and there is a constant pressure between a very hard surface and the piriformis muscle that leads to inflammation. This is just one of the dynamic scans, and I hope that we will have the time to show how this dynamic scan is there, where you look for the movement of the free movement of the piriformis muscle when we are doing a flexion and an extension of the hip joint from the back, and wanting to see for the sciatic nerve. So that's just a dynamic scan here. I hope somebody has a piriformis muscle. So that's a piriformis here. And of course, we look for the femoral stress fractures. We do not ignore them on x-rays, but sometimes we do tend to overlook. And when we do a scan, so it's just up to your clinician that he wants to go further into and try and find out, even though he has apparently a normal x-ray, that there is a fracture or an occult fracture they may be sitting there. Posterior hip. The one image that would be lovely for you to carry back home, just one image I'm saying, of the posterior gluteal scan or an exam is this one short axis image. We put our probe in a short axis scan at the gluteal fold, and the structures that we see are these. If you get the hang of these structures, believe me, the posterior scan of the hip is going to be child's play for you. So I'm just going to run over the landmarks one by one. Because this is the biceps femoris short axis scan, naturally, this is the lateral side of the scan, and this is the medial side of the scan. What we have in the middle is the conjoined tendon of the biceps femoris and the semitendinosus. So in between the semitendinosus, we have the conjoined tendon. This conjoined echogenic tendon along with the sciatic nerve on the lateral side. So sciatic nerve runs deep to the biceps femoris. I hope we'll remember that in our long axis scan in the live demo. And the semitendinosus muscle belly, underneath lies the semimembranosus tendon. So that's a semimembranosus tendon, which is very small at the level of the gluteal fold. That's the semitendinosus belly. Along with the conjoined tendon, they actually form what is kind of called as Mercedes sign, Mercedes-Benz sign. I know this triangle that you can see, but do try, keep this triangle in your mind, and every time you're running through your posterior scan, do get this configuration, and you will know that's biceps femoris, so there's a semitendinosus, and as you run distally, you will see the semitendinosus muscle belly keep becoming smaller and smaller, and the semimembranosus growing bigger and bigger along the aponeurosis from where it takes its origin. So with this, I will just come again. That is the gluteus maximus running through the short axis scan. See, this is the posterior scan. This is ischial tuberosity and a greater trochanter. So if you align your probe right along the plane, what you're going to see is the greater trochanter, ischial tuberosity, the origins of hamstrings, quadratus femoris, along with, this is just one of the views, so you see one after another, quadratus femoris, piriformis, obturator internus. So don't miss them, and don't think that quadratus femoris is piriformis, because under the piriformis you will see the sciatic nerve and of course the gluteus maximus here. So I think that would be the end of my hip joint presentation. Thank you very much indeed. This sign is just not to say thank you, but I truly believe I leave a part of my heart here in Aurangabad. Thank you.
Very much, ma'am.
Totally, sir. That's very important, sir.
Now we will proceed with one case and a finger demonstration.
So we have a very interesting case here of finger injury. This gentleman is a mechanic, and if you can see, there is a laceration injury which is involving his middle finger. And we're just going to do a small clinical exam here. अपना हाथ को मोड़ कर दिखाओ. Wonderful. मुड़ जाता है पूरा? ठीक है. इतना मुड़ जाता है, इसके आगे नहीं मुड़ता. Alright. अभी मोड़ कर देखो. इधर से मोड़ो. नहीं, देखो जैसे मैं. So what I'm examining is the integrity of the flexor digitorum profundus and superficialis. So what he showed right now was that his superficialis tendon is working because he was able to actually move the finger in a manner like this. For flexor digitorum profundus, what we do is that we have to obliterate or completely ignore the superficialis. So I'm just going to hold his and now ask his, this is a normal finger, all right? I'm so sorry. Right. Abhi apna ungli ko modo idhar se. Perfect. See how he's able to flex this at the level of distal interphalangeal joint? भी इसके ऊपर आप focus कर सकते हैं? Okay, so I'm going to ask him again, मोड़ेगा? So he's able to flex at the level. He will not be able to do this if I ask him to do it individually, right? So you have to just completely stop the flexor superficialis working and flex kare. So his flexor digitorum profundus is intact here, but as I ask him to flex here, he's unable to flex. See, he's unable to flex at the distal interphalangeal joint. So I'm just this is not the reason why we are doing that we will be able to conclude our ultrasound on basis of this, but this is just gives us a leeway as to where we are going. I'm going to start from the palmar region, and from the palmar region we are going to first graduate and see the fingers and try and find where exactly is the deficiency. I've taken a very high frequency probe that is going up to 18 megahertz, and this is place where we would have loved to have a hockey stick probe, but 18 megahertz is just as good. The only thing that we have to take care of is that we keep our probe extremely lightly, not to press on the very superficial structures and obliterate them. So we are from in the mid palm region. Is this better, sir? Yeah. Okay. So we are in the mid palm region, and what we see is a combined tendon complex of flexor digitorum superficialis, and underneath that flexor digitorum profundus. And this is how we will be seeing at all the levels. In between them, of course, you see the lumbricals and you see the interdigital arteries. If I put in the color Dopplers, these are the interdigital arteries. You can see them very well. And let's not miss them and call them fluid spaces just because there is a history of injury. So as I move my probe distally, and I'm just going to be focusing on the normal first, okay? So we are just going over the normal, and this is what I am on the middle finger, and I can see the middle finger actually the tendon of I'm just going to make some depth arrangements here, okay? So this is primarily a short axis scan, and we will go on to long axis should we find a pathology. And this is at the level we can see the two tendons of the superficialis and the decussation right in the middle of the profundus, because right now I am at the place. Does it need more gel? Give me a minute, sir. Isko saath mein rakhega. Wonderful. So, right. So we are at the level, right. So this is the level. We see the two tendons of the flexor digitorum superficialis, and the decussation starts at the level where the profundus has already decussated, right there, right there. So the decussation has been done, and we move further ahead. I look at the normal A1 pulley, which can be seen right at the top, right there. So there is no thickening, no pathology that I can evaluate at this point. I'm again at the metacarpophalangeal joint for the normal. I can see the A1 pulley very well right there, and the thickening is normal. So now from here, I'm going to move on to the area of interest, and that's the middle finger. I am right here at the level of the middle finger, and metacarpophalangeal joint can be seen. The tendons of the flexor digitorum superficialis and the profundi can be seen, and I can also see a thickened A1 pulley, a little bit of thickening that is seen on the radial side, which I am going to just keep it at the back of my mind, whether that's the thickening or it's just a variant. So no, I don't think there is a thickening there, but from here on, I am moving distally along the finger in a long axis scan in order to have an overview of the injury. And as I go, what I am seeing here is completely an altered pattern. I'm seeing thickening of the soft tissues superficially, a lot of thickening of the soft tissues that can be seen, and underneath the fibrillar pattern of the complex of superficialis tendon is also a little more hypoechoic than I would have thought. So I'm going to just quickly jump on to the normal side to give you an idea as to what a normal tendon should be looking like. If you can see the normal tendon right there, a perfect normal tendon, and if you can please see the underneath fat, which is so well demarcated at this level. However, when I go to the injured finger, I'm right here. You can see that there are hypoechoic rents which I can see in that fat. Also, there is a thickening. So I'm going to go in my short axis scan to evaluate the thickening, and there is a tear which I can see. There is widening of the area of the, so we are having normal superficialis tendon right there, both the superficialis, but at this level where there is a decussation, I see a whole big altered echogenicity. So I'm just going to try and find out from where do we have an intact profundus, as I am at the level of the distal interphalangeal joint. At the distal interphalangeal joint, I can see that there is an intact tendon. The tendon is totally intact and taking an insertion at the level of the base of the phalanx, at the base of the phalanx. And as I go distally, I can see the profundus well demarcated. However, as I come at the level of the middle interphalangeal joint, there is a scar tissue which is seen engulfing. That's the scar tissue. That's the scar tissue which is actually engulfing. This is not an isotropy, but there is a thick scar tissue at this level, a very thick scar tissue which is engulfing the entire complex of the superficialis and profundus, and it is primarily the scar tissue which is not letting the free movement of the finger happen. The tear is not there. I am just going to come to my A3 pulley at this point and see whether the A3 pulley is intact. So if you could point to the A3, yeah, so that's the A3 pulley, and I can see the A3 pulley. I can see the complex. Again, there is a scar tissue which is engulfing the entire complex, that scar tissue right there, which is engulfing the superficialis and the tendons. There is no tear that I can see of the superficialis and profundus, because this complex shows an intact profundus at the level of the middle interphalangeal joint. Both the superficialis tendons are there, and in the center you can see the profundus, and as I go distally, I can see in my long axis that profundus is actually well into the level of the base of the distal phalanx. So it's primarily a soft tissue injury with a lot of scarring which has taken over and engulfed an entire system, and will need to be either debrided or he needs a plastic surgeon for this entire. And this is the reason why his profundus is not working, because if I do passive movement, see, this is a passive movement, and you can see that there is a good movement at the distal interphalangeal joint. So my profundus is definitely intact here, and so is my superficialis, because if I try and move my finger, the movement of the finger at the metacarpophalangeal joint is also intact. So it's the scar tissue which is actually causing the problem at this level. Thank you.
Any questions anyone has got?
नहीं होगा. 6 के नीचे. At least newborn है तो बहुत अच्छा है. 8 months में तो ये on popular request, we
Okay.
need you to please come and give us that enthralling shoulder scan again. Thank you so much.